Friends, welcome to my workplace at Ranaghat, West Bengal, India. This is an intumescent cataract. As usual in such cases, I do two stage rexes. First a mini rexis and then an optimum sized rexis. But in this case, the intumescence was so high, the intralenticular pressure was so high that as soon as the anterior capsule was punctured by the needle, it just ran away. In this case, probably if I immediately did a can opener rexis kind of thing, which Dr. Ashish Shapkal has shown us few days back, I could have, at this time, I could see within 2 seconds it has gone. So I have no other option. I just have to make cuts and do rexis in this way. And even at this stage, I am not sure whether I will go ahead with Phaco or whether I will convert the surgery to SICS. For this, I just aspirated the cortex, and as soon as I saw this brown tinge of the nucleus, so this is a quite hard nucleus, as soon as I saw this, immediately I decided to convert to SICS, because if it is a soft cataract, we may get away, but if the nucleus is so hard, we can see the brown tinge, there is a very high chance of nucleus drop. So I didn't take time to decide to convert the surgery to SICS. So I did peritomy for about 3 clock hours, from 11 o'clock to 2 o'clock, and now bipolar wet field cautery was done, and then a frown incision was placed about 2 mm away from the limbus. And this is a very nice frown incision. This crescent blade is being used to make the sclerocorneal tunnel. First, I go centrally into clear cornea for about 1.5 mm and then sweep backward and to the left to make the tunnel on the left side, then sweep from center, sweep backward and to the right to make the tunnel on the right side. At this time, the contour of the eyeball is kept in mind, and we must take care not to cause any premature entry. And now the tunnel is opened with this keratom, and we can see this is a very nice corneal valve, and it will not require any suture. And now again visco, and then I take 2 Sinskey hooks to bring the nucleus out of the capsular bag. As I dialed the nucleus came out of the capsular bag. And now I inject visco in front and behind the nucleus. Just injected visco behind the nucleus to engage it in the tunnel. And now this is a fish hook, and with the fish hook I remove the nucleus very gently. because if I use an irrigating vectis, the irrigating fluid will give some pressure on the posterior capsule. I didn't want to do that. And now I'm using this 23G Simcoe cannula to clean the cortical lens matter. In this case, we selected a single piece foldable intraocular lens from Hanita, Israel, and I'm going to implant the same lens in the back. I'm going to keep the haptics covered by the anterior capsular rim, and I'm going to orient the lens at 2 o'clock, 8 o'clock meridian. Here goes the lens. The Sinskey hook girds the lens, and the Sinskey hook puts the leading haptic in the bag, pushes the lens, and now I go through the right side port and place the other haptic behind the anterior capsular rim, and the lens is going to be in this meridian, 2 o'clock, 8 o'clock meridian, the haptics. And now the visco is nicely cleaned. This is irrigation, actually double irrigation as well as flushing of gases through the aspirating port from the syringe to remove the visco. And now I'm going through the main wound, 2.8 mm wound, and doing some more irrigation and aspiration. And now this is bimanual irrigation aspiration to remove some more visco. Unless we become thorough in removing visco, there is a high chance of raised IOP in the post-op period. So after cleaning visco, we just have to close the incisions. This is a bit of moxifloxacin. Now I hydrate corneal stroma on either side of the stab wounds. And I find that the antechamber, the intraocular pressure is normal or on the higher side. This is the final lavage of the anterior chamber, and this is final lavage and formation of the anterior chamber. This is how the antechamber is formed. And now I check the intraocular pressure. The eyeball is firm and there is no leakage from any wound, and we are towards the end of the surgery. Now, how to oppose the conjunctiva to the limbus? Just give a subconjunctival injection of gentamicin and dexamethasone. Remove the superior rectus bridal suture and conclude the case. Thank you very much for your attention. Hope this video will help you in developing your surgical skills. Please do not hesitate to convert to SICS if you find that the nucleus is hard.